Hello, everybody. My name's Ed Pavlik, and we're doing another version of uh, Gynec Garage. It's a great day where I am. I'm in Lexington, Kentucky, and my colleague today on Veterans Day, known as Remembrance Day in the UK, which marks the end of World War I, is
Frank Lawton from a very cold and dark London, United Kingdom.
I see. Well,
Winter is coming in now.
if I pick up on cold and dark, it looks like the new Labour budget is out for the UK. How does it look for the NHS?
Well, as usual, the NHS has asked for and will be given a lot of money, and unfortunately, a lot of it has already been agreed to give pay rises to doctors and ancillary staff and nurses, something like a 5% pay rise. So a lot of that, many billions that are going into the NHS will be going on pay rises. Unfortunately, I think the NHS is a bottomless pit. Probably any health service is a bottomless pit, but I think the NHS, because it's funded by, outsourced by tax, has more political impact than one where it's insurance based. Um, it'll have to be changed sometime, but I think governments, I can't remember who said it was that the NHS is the religion of the United Kingdom, and I think that's pretty close to it. It's very difficult to tinker with it and dismantle with it. And every year the money goes up and the productivity doesn't increase. The productivity, in fact, in the UK, and I don't know how they really measure it, but on whatever outcome, is not back to pre-COVID levels. So despite all the money that's gone into the system over the last 4 years, the productivity is not what it was. So that's it.
Okay. Today, we're going to consider some questions. There are two of them. Is there a difference in survival between the treatment surgery alone and surgery preceded by neoadjuvant chemotherapy? And the second question, do stick lesions react differently to neoadjuvant chemotherapy? Answers to these questions are approached in two papers. The first is in the American Journal of Obstetrics and Gynecology, titled Survival Outcomes of Primary versus Interval Cytoreductive Surgery for International Federation of Gynecological Stage 4 Ovarian Cancer. And the second paper is Serous Tubal Intraepithelial Carcinoma after neoadjuvant chemotherapy, a report of two cases. And it comes from the International Journal of Gynecologic Pathology. This work is important because it looks at how survival may be affected by nuances related to treatment. Today, again, we're going to involve artificial intelligence into our reviews, but Frank, give us your human insights on this paper.
Okay, I'd like to start with the conclusion and work backwards from this paper. The conclusion is that primary surgery is gives a potentially superior outcome compared with intervention surgery in terms of progression-free interval and overall survival. Now, the authors take on these data, despite the fact that there have been probably 4 randomized controlled trials looking at exactly the same thing. One from the UK and parts of Europe was Chorus. The EORTC has done a study. There was an Italian-led paper, Scorpion, and a Japanese paper as well. And essentially, they've all shown that IDS is not inferior, or for that matter, primary surgery is not superior for the outcome for ovarian cancer. And I think the consensus, certainly from Europe, is that if you don't think you can get all the disease out by primary surgery, then it's not unreasonable to give primary neoadjuvant chemotherapy and then have a go. The Chorus EORTC data were criticized because of the low complete excision rates in the studies and also the low median survival. And that may be the reason why this French group has decided to do a slightly different nuance on the study. So either they didn't know the data, which obviously is not true. They did know the data, but didn't believe it, which I suspect is not true. They did know the data, they did believe it, but they didn't think it was relevant to their patient population. Or within the patient population, there's a subgroup that this group thought might benefit from it. And what they've done, and I find this quite a difficult concept, they've done what a target trial emulation. What happens is that you imagine a trial that could have been conducted based on the data from the real world. So observational data, not an RCT. The complaint against RCT is that there are so many limitations that this is not the real world. These are not patients that come in through the door of the surgery or the hospital and have treatment. So what they've done is looked at their data over a period of time from French data and have cloned a copy of each patient and then randomized them into one of the two, or put them both into the arms of the study, and then essentially, I think, waiting for something to happen and then sent them when this thing has happened. The problem, well, there are a number of problems, and I think one of them is that their median progression-free survival, which is what they say, which is why they say is an improvement, is actually not much better than the Scorpion data. The Scorpion data, median overall survival, 49 months versus 44.3 months, median progression-free survival, 15.1 versus 16.4, primary surgery versus IDS. And in their study, median progression-free survival, 19 versus 15.5 months, median overall survival, 63 versus 56 months, 53 for primary surgery, 56 for IDS. They say that the 5-year median overall survival is 4% better, and you've got an increased life expectancy of 3.9 months at 7 years. So although the data statistically are probably okay, I don't think the outcome is as good as they say. I think another problem is that the database, they've looked at a number of factors. One that they don't mention is whether or not all these ovarian cancers are epithelial in nature. The histology is not reviewed at all. We could be dealing with non-epithelial tumors, or indeed we could be dealing with metastatic colon or other tumors that have been classified as ovary in the original paper. We also don't know the molecular profile of these tumors. We don't know the grade of the tumor. We don't know the residual disease or the size of the primary lesion. And there have been data, Neville Hacker presented data many, many years ago saying that if you're starting with disease greater than 10 centimeters, no matter really what you do, the prognosis is worse. And all of those data are missing. So essentially, the database that they are using, there can be a lot of confounding factors that they can take they have no notice of, and they don't know anything about it. I think the other thing that's interesting is that the median overall survival, let's say for the primary surgery of 19.7 months, median progression-free survival of 19.7 months, but the median overall survival of 63 months. This suggests to me that this is not the surgery that's the main contributor to the survival data. It's the chemotherapy that the patients were given, and probably we were talking about chemotherapy at relapse, or PARP inhibitors, or angiogenic inhibitors. I'm not so sure that this study actually separates the surgery from everything else. It's far too complicated, and I don't honestly believe that this is very much going to change management, except this could be seen as an easy way to carry out a study without having to do a randomized control trial. The RCT is still the gold standard of treatment, but it is difficult to set up. You have to do it for a long time, etc., etc. This may be seen as a statistically easier way to get results, but I'm not so sure that the results are actually transferable in comparison with an RCT. So I think it's an interesting paper. It is flawed. It ignores the fact that there are good data for randomized studies, and I don't think that the database that they use is robust enough to justify this outcome or these conclusions.
Yeah, I agree completely, Frank. The residual disease problem is sort of surprising because it's so well known. It's been so long standing. I will, say that the model that they choose is rather new. It's rather new to me. The supplementary material just lights up in the manuscript, and it doesn't read easy for a person who's taking care of patients and wants to, really have confidence in what they're reading. With regard to what they've tried to do with the intent to treat situation, I really didn't understand it. I would have preferred that they would have handled it both as a without intent to treat as well as with intent to treat, so they could see if there was a difference in a trial, intent to treat can be quite different depending upon which trial it is. So, that was one comment I had. Now, my last comment is about the artificial intelligence, and there, neither Copilot or Gemini read the paper. They generated numbers from the internet, and they didn't abide to the command creatively analyze this paper. So we don't really get any information from artificial intelligence, on this go around.
Well, yes, I mean, the other thing that I forgot to mention, they don't talk about toxicity. Well, they talk a little bit about toxicity, but it is fairly well known from the RCTs that the toxicity of neoadjuvant chemotherapy and IDS is less, the surgical morbidity, etc. Although interesting, they say that the morbidity it was higher in the intervention arm, in the IDS arm, neoadjuvant, which surprises me because you would have thought that the patients get pretty much the same chemotherapy. Platinum Taxol base, 3 to 6 cycles, and then surgery. So is the toxicity of the other arm, the IDS arm, associated with the further chemotherapy that the patients are being given? It's very difficult to separate a lot of the data in this study, and I think that's that is the main weakness. I think a lot of the prognostic factors that we know about and we accept have not been at all addressed in this paper. RCT may have its limitations, but I think it produces much stronger data than this study can.
Sure. Well, let's skip over to another paper. And this paper is basically a limited case report. But what we can say about it is it makes a very important point. And really, it considers two women. They basically have ovarian cancer that's confirmed by biopsy. And then they're treated with 3 cycles of neoadjuvant carboplatin and Taxol, and then subject to complete debulking. When the complete debulking is analyzed in the path lab, they find that there's been a complete histopathological tumor response on the primary tumor, on the ovarian site. But when they look at the fallopian tubes, they find very viable serous interstitial tumor, serous tubal intraepithelial carcinoma, excuse me. So and both of these sticks look like they're the real thing. The stick from the first woman basically has overexpression of P53, and then the panel that is shown for the woman number 2 is really a null mutation stick, but nevertheless, that's what they found. The idea here is that we should raise the question: is this important in the subsequent treatment of people? In other words, with a known quantity that the proliferative index of sticks will vary between a low number and a high number, 10 to 90%. Should we know when it's low? And if it's being a low proliferative stick, it'll resist chemotherapy because it's dividing so slow that chemotherapy doesn't work on it. It's almost like a borderline tumor, that type of thing. So should we connect with collecting this type of information clinically? Now, of the 2 artificial intelligence approaches, Gemini did a very good job. It was spot on, but Copilot had some mistakes, and it had basically it really did an analysis that was extremely superficial and incorrect. It would probably be adequate for a sub-8th grade, sub-middle school student in the States to get a C, that type of thing. But it was totally inadequate from the standpoint of people who are anywhere in training. So, Frank, what do you think?
Yes, it was quite an interesting study. One of the things that I picked up on was that, of course, the majority of patients with ovarian cancer at some time will have their fallopian tubes removed. So the pre-malignant potential of stick within the fimbria or wherever it is should be removed by the surgery. That's the first thing. Second thing is that analogous to ductal carcinoma in situ, that isn't chemosensitive either. Neoadjuvant chemotherapy given before mastectomy sometimes does produce a diminution in the size of the known ductal carcinoma in situ, but it's usually a surprise to breast surgeons and breast oncologists if there is a response. So I think the fact that this pre-malignant lesion, which I think we accept, everyone accepts is pre-malignant, the fact that it doesn't respond to chemotherapy is probably not that surprising. Not many pre-malignant conditions do, because as you've said, their rate of multiplication and turnover is so low that they're not acting like malignant cells, they're acting like pre-malignant or even normal cells. But I think it further adds to the belief that stick is the precursor, or the fallopian tube is the precursor of the majority of, certainly of serous epithelial ovarian cancers.
Yeah, and I will say one thing though, is that say on the prophylactic surgical cases, if in fact the stick has had a chance to have tumor cells come out of it and leak into the abdomen, then of course there's going to be a appearance of disease, which we know from the literature does occur. Now, if the same thing happens after the defined malignancy has been declared, once again, those cells will probably evade chemotherapy, NAC chemotherapy.
Yeah.
So I mean that's probably where this fits into things. And of course, we're dealing with a problem that's submicroscopic, of course, then below the surveillance of the human eye during surgery. So,
I suppose one of the problems, if we relate this to intervention surgery, is that if there is a stick within the fallopian tube at the time of diagnosis of ovarian cancer, and then there's a 3-month or 4-month interval between starting primary chemotherapy before definitive debulking surgery, removal of the fallopian tubes, is that a 4 months of the potential for stick to spread from the fallopian tube, since it is not chemosensitive. So in a way, that may be a factor to consider when you're considering delayed primary surgery, because you've got 4 months or whatever it is. I mean, some people are given 6 cycles of chemotherapy before IDS. So we give them some period of time when stick is very happily spreading and it is chemo resistant.
exactly. Well, very good. It was good to get together on a Gynec Garage with you. We'll do it again next month.
We will indeed. See you then.
Okay, you take care, Frank.
And you. Bye-bye now.